Hi, happy May. I'm Mehek Kalra. It's weird because I would usually say happy Derby weekend, but things look a little different around here for everyone. So, hi everyone. I hope everyone's doing well and staying safe and healthy during this time. I encourage everyone to use the chat feature to say hello. And also, I just want to kind of ground us all on why we're here today and what the conversation of today will be. So we're going to get a shared understanding of phase one of the healthcare services reopening and the guidance that is put out to the oral health community. We're also going to have a panel discussion with the Kentucky Board of Dentistry, the Kentucky Dental Association, and the Kentucky Hygiene Association around the guidance document and also the needs of the state. And lastly, we're going to be providing updates from the two dental schools here in Kentucky about their practice and their procedures. So with that being said, I'm just going to quickly go over some Zoom housekeeping notes. As a reminder, this Zoom meeting is recorded. Everyone's audio, unless you are a part of the webinar, is muted. So conversations are going to look a little different than they would normally. Please use the chat feature to ask your questions or to have to add any commentary from our speakers. I do want to remind everyone that the chat function is set so everyone can see it. So if you want to send a message to someone privately, please do so with your own device. It just makes things a lot easier that way. Also, I just, as a note, that this webinar is brought to you by the Kentucky Oral Health Coalition. So if you aren't familiar with the coalition or our work, the goal of the coalition is to improve oral health for all people in Kentucky. And so if you would like to get more familiar with us and the work that we do, please visit our website and also view our social media channels. And before I turn it over to Dr. McKee, I just want to take a second to share my sense of gratitude for the reopening work group. This work group had a tough task. We worked as a team and needed a diverse group of perspectives and partners to work together to really reduce the spread of an infectious disease, but also make sure that we're giving guidance that is evidence-based to ensure that our patients and the patients that you all have every day receive the care that they need. So just wanted to ground us all on that. And then I'm going to just turn it over to Dr. McKee and let you do the fun part.
All right, thank you very much. Just to remind everybody, I am Dr. Julie Watts McKee. I use Watts because my dad and my mom helped me finance my dental education, and that's the least I could do for them. So I'm the state dental director of the state of Kentucky, and I know most of you all are at least familiar with your name and yours with mine. Today we're going to briefly go over how we got here and what is expected of us and what is not expected of us and what we need to be looking at in our own practices. My part is actually going to be pretty quick and dirty. It's very casual because I wrote my presentation when I was dog tired. So it's not full of a lot of peer-reviewed journals and stuff like that. It's just kind of what happened as far as where I came from. I do want to reserve incredible amounts of time for questions because this is weird. It's wonderful, but it's weird. But we still want to take our time with questions to make sure we understand each other and why things are the way they are. Okay, slide please. All right, we hatched a plan. And when I say hatched, I really do mean it happened quickly and we broke out of our own shells to get there. So this is how it happened. Just a little bit of back history so you can understand where we were when this happened. On March 1st, we had our first COVID case in Kentucky. On March 16th, I'm in a cow pasture. I keep hearing cows moo. I don't know where that's coming from. But anyway, on March 16th, the governor asked healthcare providers to reduce direct care to essential services only. And the dentists began and continue to invoke the 80-20 rule. 80% of the dentists said, okay, I don't like it, but I think I understand. I can do this. And 20% said, not going to do it. Watch me. I mean, that's one of the directives I heard from most dentists who decided not to comply was watch me. So 48 hours later, the governor, in Julie's words, said, you know, I ask you nice. Now I'm going to tell you. And that's the date that the directive from the Secretary of the Cabinet for Health and Family Services came down with a directive that said, not going to happen. It's not going to happen. You can only provide essential care. And so that's where dentistry was on March 18th. Essential services, what does that mean exactly? And I kept hearing all the time, I want an exact list of what I can and cannot do. I cannot give them that list. They had to create their own list to see what it was, because I could argue many situations where either were essential that in the end were not, or just the opposite, that did not look essential but actually were. And it's really funny, and this is not in writing, but it's being recorded, that it's that they wanted me to come up with a plan and their exact list on what they could do and who they could do it to. I'm like, you all don't even think I'm a real dentist. Why are you even asking me that? Next slide. It is important that even then and now, that the individual, the licensed professional, must make essential or non-essential care decisions by using their professional judgment that's based on their education, their training, and their experience. Remember this line. You're going to hear it again in just a few minutes. So, some dental offices fully closed. Some of the dentists were within the definition of vulnerable populations, and so they did it to protect their own health. I'm down with that. Some just closed, didn't even leave a contact number for emergencies that may have happened in their patient panel. Some continued to provide care that was urgent or emergent for their patients of record. Some continued to provide care for emergent and urgent cases that anybody, they were seeing anybody that called them that felt like they had a dental emergency. Once again, we were about in the national average of that 80-20 rule. I do believe that national organization, maybe the ADA, said that they felt like that only about 15% of general dentist office were currently doing services during this period of emergencies only. Slide. So back then, just a couple, maybe a week or no, probably 2 weeks after that, a work group of dental professionals began work. And it was a multifaceted group that was based on providers. We wanted to target providers. This was a plan for dentistry to resume expanded care. And at the time, we felt like there was a lot of time to do this because the White House had just come out with a recommendation of, we're not going to think about reopening till we see 14 days of decreased cases or something like that. And we felt like we had time. We felt like that our plan at that time was a well thought out plan. It was evidence-based. We wanted to put it together and collect input from all the stakeholders, get their comments, incorporate what made sense. And so we would have a plan for all of dentistry well in advance of when the dentist office would open. And we were pretty proud of ourselves. I still hear a cow. Does anybody hear a cow? Mm-hmm. Okay. All right. So it was going fine until apparently there were some dentists that were complaining to the correct people that they needed to get back to work, and they needed to get back to work now. I was unaware of this influence at the governor's office levels, but on April 23rd at 5:23, the governor announced that dental offices would be opening that next Monday. The U.S. Geological Survey recorded seismic activity across the state at that time because it was jaws dropping all across the state, including mine. We had no idea. Nobody was consulted. I did not know about it, sitting here in the Department of Public Health, and nobody had a heads up, but here we were. Slide. So the work group felt their mission was put on warp speed at that time to develop a plan that was workable submitted to the governor as soon as possible so that dental offices could, in fact, open on Monday in accordance to what the governor wanted to do. 3 words: blood, sweat, and tears. I think most have experienced all of those things, some of us more than others. The work group, when I say work tirelessly over the next 48 hours, that I don't know how else to say it. We were contacting each other way into the night. We would have Zoom meetings and conference calls at crazy hours to try to get done what we needed to do, get done what we needed to do. So what we did is we took Dr. Stack's checklist of the requirements for all healthcare that could have opened on that day and addressed how that was going to look at a dentist office. We took his concerns specifically about PPE and aerosol management and fleshed those out too. So those were concentrated. We also went over some other things that we wanted Dr. Stack and the governor to know that we were going to do, that we felt was kind of a value added knowledge part of the document on what we were going to do, what we could do, what some options were. Slide, please. We had a bunch of people. Golly, what a great group we worked with. I was really, really impressed. It's amazing what you can do under that pressure and with the blood, sweat, and tears flowing. This plan was agreed upon by the Kentucky Dental Association. They were our catalyst for bringing this group together. The Kentucky Dental Hygienists Association, the Board of Dentistry, because they have to enforce the law, the Kentucky Oral Health Coalition, and our 2 state dental schools, the University of Kentucky College of Dentistry and the University of Louisville School of Dentistry. So I had a phone sit down with Dr. Stack on Sunday morning, and because I think we submitted it maybe at 8:30, 8:50 on Saturday night. So Dr. Stack called me on Sunday morning, and we sat down over the phone and talked about it. And he was so impressed on how detailed it was. And I actually laughed out loud. I mean, like rude, laughed out loud, because I'm like, you really don't know dentists and hygienists, do you now? Go ahead. So because even though it was 117 pages, I don't know, 6 pages, the design of the plan was purposely broad. We incorporated the standards that Dr. Stack wanted and the governor wanted, but we also left a lot broad by design. This isn't the last edition. This is just the first edition. Every time that this group talked, we talked about it being interim and fluid and plastic and living, whatever word you want to give to it, that this is going to change. It's going to change for a bunch of reasons. Good feedback that we've already gotten. It's going to change as the pandemic impacts not only our state, but different areas of the state as we do that. And it's going to change because we have science emerging every day relative to response, relative to prevention, relative to mitigation and control. It's all coming at us at lightning speed. OSHA requirements this morning at 9 o'clock for one. So the broadness is intentional. We did not mean to leave anybody in a lurch and anybody hanging, because the interpretation should consider the dental professional's mission. Every dental professional has a different mission. A FQHC has a different mission than a corporate dentist office. A university clinic has a different mission than a private sole proprietor in a small town. We all have different missions. The layout of the office is all different. It'd be silly for us to talk about barriers, plastic barriers must be put up. If you were in my office, which was built in 1968 or 9, that every treatment room was its own room, drywall and doors. So we didn't want to do that. It also depended on the available resources of the practice. We know that that's a challenge right now. Slide. One of the reasons we left it broad goes back to the things that we talked about relative to trying to determine your list of essential and non-essential. The individual must make care decisions using their professional judgment once again, based on their education, their training, and their experience. We're starting to see that language in other states' plans too, to do that. Slide, please. A dentist can only open when the guidelines referenced are met. The biggie things that Dr. Stack talked about and the governor is wed to is appropriate PPE. They didn't say level 1 hazmats for every patient you see. Appropriate PPE. They also are very concerned about aerosol management, and they have reason to be. This is COVID-19. What we're fighting right now is an aerosol transmitted disease versus back in the 80s when HIV was a bloodborne transmitted disease, and we need to pay more attention to that. Now, this is, it's not all bad. It's not all bad. We probably should have been paying a little bit more attention to aerosols as it went along. Go ahead. All right, so April 27th, that day was the magic day for us. This allowed offices to open, but just as important, it allowed offices not to open. There was no requirement that an office must open. This is not a race. It's just an allowance. Speaking of Oaks and Derby, this is not a race. Open when you're ready, but not until. Remembering those two big things that Dr. Stack is wed to, and that is appropriate PPE and aerosol management. Go ahead. The broadness of this, hopefully, and this was talked about in our work group, hopefully the broadness of this plan offered respect. It respects the offices that opened on Monday. It respects the offices that won't open until May 4th, May 11th, June 8th, the 12th of never. You be you, whatever is safe for you. I'm aware of some practices that are thinking about not opening at all. Go ahead. Oh, you did. The plan will change. Here's some ways. The governor's directive is going to change as we move through this pandemic. It's not going to be as severe as it is. We're going to be able to loosen up as the pandemic eases and as we can control the COVID-19 and as possibly testing is better and a vaccine is approved. We need to rework some of the language. There's a mistake in there that is my mistake alone, but nobody else caught it. But anyway, I mentioned non-latex gloves. That's my bad. I thought that was an industry standard. If you use latex gloves, that's fine. That's a professional judgment that is easily allowed to do that. Now, I would think that if you do use latex gloves in your practice, that you might want to make sure that your patients know that that's a possibility in the latex exposure is a possibility in your practice. Go ahead. So the work group continues. We knew that our work wasn't done, but we have taken a little bit of a break to kind of let the level find itself and see what we need to work on. We'll revise it as many times as it takes. We want input. We're getting good input. We're getting some pretty snippy input too, but we're getting some good input in order to take those under consideration and see how that can be applied to our current plan as it matures. We're developing an FAQ sheet that what about this, what about that, what about this, and that's going to be ongoing and updated often, and hopefully we'll be able to publish that for everybody, and it will be easily accessed, and because people need some answers, they want some answers. We will probably continue to keep it as broad as possible in order to respect the individuality of dentists, hygienists, and their practices. Next. Golly, out of every storm is that silver lining, and there's a lot of stuff that we can do and probably should adopt at least as current practices and maybe later as permanent ones. Better patient education. I just made a video for the cabinet that talks about what patients will be seeing that's going to look different when they go to the dentist now. And one of the things that hopefully the thoughts I left them with is, if you see something weird, ask about it. That dentists and hygienists are excited that you're interested in what's going on, and they would be glad to explain. So I think we have a chance for better patient education. We have a great opportunity for more teledentistry when it's appropriate. And the dentists I know that have started using teledentistry are like, oh yeah, that's not going away anytime soon. It gives them the opportunity to see a patient that they may not need to get intraoral as deep as you would think they would. It's a great triage tool as well. So I think that's here to stay. We have an opportunity to adopt more non-aerosol techniques that actually do control dental disease. I'm not in on the political action part of the KDA or the ADA, but dentists hesitate to use these techniques because the reimbursement is not what it should be. Let's be honest. So if we could take the time to convince the powers that be, meaning the powers that pay, to recognize that our non-aerosol producing techniques to control disease need to have some type of monetary parity as well. It's an opportunity to provide a safer work environment. We've all dealt with aerosols. This just brings it to the forefront, and maybe it's time to look at it. It's really interesting because I began practice right when universal precautions came into play. I went to dental school without gloves, except for perio surgery and oral surgery. And so using gloves for everybody was like using mittens for a while, but we all got used to it. We all got used to every part of that HIV-based infection control. And I heard so many times, we probably should have already been doing this anyway. So these are coming about in attention to aerosols and how we can manage and mitigate and reduce them. And once again, I hear dental voices saying, we probably should have been doing this anyway. Slide. Will it last forever? I don't think so. I really don't. But we are allowed to provide dental services during still the outbreak of this. So we've got to move carefully and with great thought. But remember, everything's in place for now, and we have broad interpretation, but there are certain things you've got to be doing now. Some of the changes that we see for now will probably trickle into dentistry in the future. I can see us doing better screening about how you feel right now, today. When you come in as a patient, I can see that. I can see a little bit more barrier. I can see air filtration coming more into play. I can see, hopefully, those non-aerosol disease management techniques come into play. But it's not, some of it will go away, maybe a lot of it, but I don't think all of it will go away. We are changed for good and hopefully for the better. Next. Oh, guess what? I'm done. Put your questions in the chat box. We're going to have a panel discussion, and Mehek's going to start that kind of a response to the situation and maybe what I said. Yes. Thank you for listening.
Thank you, Dr. McKee. That was a wealth of information for all of us to take in and soak in. And so, like Dr. McKee said, if you have any questions throughout this period, feel free to use the chat feature. That's how we're going to go ahead and solicit some input from the folks on the call. And I know there were some technical issues before with Zoom, with folks trying to log in, but I think we have it all figured out. So if folks, if you have colleagues that are trying to join right now, feel free to let them know that they can join. It's available for anybody and everyone. So at that note, I am going to go ahead and start the panel discussion. So I know that we might have a couple folks that are going to be tag teaming and joining. So Dr. Moats and Dr. Greenwell are going to be representing the Kentucky Dental Association. We have Jeffrey Allen as well, and also Dr. Ball and then as well as Lynn Phillips representing the Dental Hygiene Association. And so I am just going to ask this broad question to each of you all, because we each represent different sectors here and different stakeholdership. So one of my first questions is going to go to Dr. Greenwell and Dr. Moats, which is, given the phase 1 healthcare reopening, dentistry plan provides initial guidance for dental practices that we as a work group hope protects dentists, dental hygienists, the dental support teams, and the patients. From your professional lens, what are key points from this guidance that you want to share with the virtual audience? So Dr. Greenwell or Dr. Moats, you could take the first question.
Okay. Darren Greenwell here. I think that, you know, the guidance, first of all, I just want to thank everyone that put forth the effort to get these guidelines in. It was chaotic. We were all very surprised. I think the leadership of Dr. McKee was key. I just can't thank her enough. Such great people, minds coming together, and I think developed such a great guidelines. These guidelines, I think, are here to protect ourselves, our staff, our patients, and clearly dentistry needs to get started back up. During the emergency crisis, I had to deal with some severe emergencies for, you know, that may have been mitigated if I'd been able to see those patients sooner. So I think that the Kentucky Dental Association is ready to get back and take care of our patient population in a safe manner. Dr. Moats, anything else?
Can you guys hear me okay? I think the thing I would add to Darren's comments is that without question, I've kind of absorbed this process over the last few weeks. The most important thing that I can share is certainly our training gets us to the point of being able to make clinical decisions so we can move forward for the needs of our patients as we understand our situations. Being able to have that professional latitude from these guidelines is without question, I think, one of the hallmarks of a successful plan that I also note we're seeing other states throughout the country looking at and emulating to some degree. But I think the most important thing that I take away from this, and I hope to build on and carry forward, is truly the collaboration that's been demonstrated for us as a profession to work together, to share best practices, to share information in a world that's different than, you know, when we went to do our dental training and even before that, but to have access to information just at our fingertips and be able to share this with one another in a professional manner with a very high level of respect, and carry forward the message of dentistry to not only our dental teams that we have the ability to implement these practices in a safe manner, but also, as important, to carry this message to our communities, to our patients. We all miss our patients. We certainly welcome them back, and we want to do what we can to prevent the non-urgent, non-emergent care from becoming urgent and emergent. But I think the collaboration is the thing that I'm most proud of, and I look forward to continue to build on.
Thanks, Dr. Moats and Dr. Greenwell. Lynn, do you have anything to add from your perspective as a hygienist and representing the Hygienists Association?
Yeah, I think that there is a lot to be said for clinical judgment. I think one of the things that the hygienists are having issues with is going back and seeing regular prophies right now. They would rather focus on some of the more advanced things, scaling and root planing, periodontal maintenance, seeing people that have, you know, heart problems or whatever. Those are the ones that are more critical instead of just routine care. I think that that's one of the main concerns that they've had. As far as other concerns that the hygienists have had, can I have that slide put up, Mahek? Thank you very much. They're all concerned about protection. I've had several reports saying that doctors are not doing what they are supposed to be doing. And what they feel the doctors are supposed to be doing is N95s, shields, different versions of PPE. They feel like they want more set guidelines on PPE. But if you see on the slide, 84% of the hygienists that responded to our questions, 84% thought that they should wait to come back, take care of some of the more, not necessarily emergent or urgent, but some of the more critical, large restorations, crowns that need to be done. Take care of those things first, the first couple of weeks. That seems to be what everybody is pretty much concerned with. But largely, a lot of the hygienists are concerned about their own family or their own comorbidities, because there is such a lot of questions that still need to be answered. They're concerned with the aerosol. How is that going to be controlled? Just different things. Are they going to be given extra time for infection control? I've heard so many reports of offices opening with a regular schedule, and they just didn't have time to really figure things out. So what we have done, and Dr. Moats and I have talked about this extensively, there needs to be open and honest communication between the hygienist and the doctor and the rest of the staff about what's going to make you feel comfortable. I know from my personal experience, my doctor has been fabulous. He has asked us what makes us feel comfortable. Right now, we are not going back anytime soon. We are still seeing only emergency and urgent. We are low on PPE. We have stuff ordered. It's not in yet. I am high risk. The other hygienist has an extremely high risk child at home. We have both said if we have what we need, we're more than happy to go in. And even if there was something now that was critical to see a hygienist on something, he knows that I will go in and see that patient. So I think a lot of that, just collaborating with our doctors and having open and honest communications. We all understand that in order to keep the doors open to a practice, we have to have the production, but we have to be able to do it safely. I think that's probably the main things that the hygienists are concerned about, but it has been great working collaboratively. I know Dr. Moats and I have had so many conversations, and I'm not sure that the hygienists and the dentist have had that level of open and honest communication between KYDHA and KDA in the past. So hats off to Dr. Moats. It's been great working with you.
Thanks, Lynn. And I'm going to go back to the question and talk about what are the key points from this guidance do you want to share with the virtual audience? So Dr. Ball or even Jeff Allen, if you want to share from your perspective.
Well, I would say the key guidance for me is just honestly a recognition that this is our first go at this, and this happened very quickly, and it was a collaborative effort from a lot of important people who represent all aspects of dentistry. These guidelines will change. If you have concerns about them, please let us know. You can email our office and we will take all of that into consideration. But for now, please know that these guidelines are subject to change. There's a lot of confusion out there. I know that these are a little bit different from the CDC guidelines, which are a little bit different from the OSHA guidelines, which are a little bit different from other guidelines. These are unprecedented times, and we're all trying to work together to come up with the best solution for everyone. So I would just say and reinforce the idea that we are all in here for everyone's best interest, and we are focused on keeping everyone as safe as possible.
Thank you. Dr. Ball, do you have anything to add to that?
No, I think Jeff hit it pretty well on. Just be flexible, and a lot of people that try to go beyond the minimum. That's and try to stay in tune with not just what we put out, but also what's getting put out as the latest literature. I mean, you got to stay within what we say, but if there's new literature that says do this and it doesn't contradict what we've already put out, you probably need to look at start doing that, because we are probably going to be looking at that as well. So try to stay ahead of the game.
And I think, you know, good faith effort here is important for everyone.
Mm-hmm. And
that's the main thing.
Mm-hmm. That's a great point. And I appreciate all the panelists kind of jumping in and answering questions in the chat feature as well. So thank you for doing that. And please feel free to use that chat feature to ask questions so that way we get your answers answered. And know that we might not have all the answers here today. So we're recording this and we're going to be downloading a chat feature, and we'll get the answers to you as quickly as we possibly can. So kind of moving into our next question, and a question that Lynn has already discussed is just the impact or concerns that you're feeling from this pandemic to your professional organization. Since Lynn already has addressed that question, Dr. Greenwell or Dr. Moats, do you mind taking a lead and kind of sharing the dental perspective of the impact or concerns that you are kind of feeling right now?
I think that ultimately safety is at our utmost concern. Like I said, for our staff and our patients and ourselves. Economics clearly are a factor. If dentists aren't working, you know, the practices may collapse eventually. But that's secondary in my mind. Good money comes with good dentistry. It's simple as that. Bad dentistry is not going to make any money. We have to be safe for our patients, our staff, and ourselves. The guidelines state what PPE is required for different situations. And if doctors aren't following these guidelines, they're out of compliance. And I would encourage hygienists, dental assistants, patients, whoever, if dentists aren't following the rules, that can be reported somewhere. I'm not really sure where, but even to, you know, the Board of Dentistry. So I'm clearly concerned about the hygienist issues. But hygienists also have to remember that we are healthcare workers. We have all made this our life. My hygienists, who are fantastic people, every day tell the patients how important good oral health care is. And I think a prophy is good oral health care. I do understand the concerns. You want to mitigate as much as possible. That's our goal. Our goal is to treat our patients. You know, a lot of dentists have worked in hospitals. We understand the risks that we do when we get into this profession. I would hope most hygienists and dental assistants do as well. We have an obligation to treat our patients. That's maybe not that KDA's stand on that. That's me personally saying that. But dentists aren't cruel, evil people. We're highly educated, highly trained, very dedicated professionals. If a dentist is not following the rules, then it should be reported. Anything else, Dr. Moats?
No, thanks, Darren. I appreciate that, Dr. Greenwell. I would, you know, the thing that I keep thinking about as we look at moving forward is really literally what we're having to do in our own practice. You know, this week was very unique, as it may be for many of us, as we were possibly coming back into the office, seeing our dental teams again, you know, people that we care dearly about, and really having very serious discussions about the guidelines that I think we've all worked so hard to provide just a sound foundation to build from. But I think each of us in our practices, I think the thing that I would want to convey is how critical it is that we look at our situation, look at our level of preparedness, look at our PPP or PPE resources, evaluate our patients' needs, prioritize those needs, and create a plan that your entire dental team feels safe to move forward. And again, what Dr. McKee shared, and I did join a tad late, so certainly Dr. McKee, thank you for your message, your video message on social. I thought it was an excellent message. But to that point, I think that each practice will very likely look different. And I know many folks want a specific single answer. And the reality of dentistry right now with this crisis is it is going to be different for every practice. But with discussing your dental team in a confident manner, with the correct protocols in place, with the correct PP access in place, PPE access, hopefully we will be able to begin to treat these non-urgent, non-emergent procedures in a manner that's safe for everyone, and certainly meet the needs of our patients and our communities. But it's an honor to be a part of this process, and I thank you for that responsibility. But thanks, Darren, for taking the lead today. Appreciate you guys.
Thank you. Dr. Ball or Jeff Allen, do you have anything else to add that hasn't been mentioned?
I would just say that, the board's concerns, the primary concern is and always has been public safety. That's what our mission is, to provide for public safety. And frankly, the public includes healthcare workers and dental workers. So our main guidance is to try to balance the healthcare needs and the dental needs of the people of Kentucky with the safety needs of people who work in this environment. And that's the main focus that we are working on in the short term. Long term, I think we will have to look at infection control measures, perhaps reviewing regulations and making some updates to those to make some of these permanent. But right now in the short term, we are really laser focused on trying to balance out these two areas. And we're doing what we can. If there is something that you view as a clear violation, I do encourage you to report it to us, and we will investigate that, because we are not interested in anyone acting in a manner or being exposed to something that is a dangerous situation.
Dr. Ball?
So I think Jeff and Darren both, very similar message, and ironically, I was replying to somebody's message about why are we doing this if the CDC and OSHA say that we shouldn't be. And so if you check the chat, you can read my message. But basically, we have competing issues. We're neglecting people, and it's causing irreversible health harm. And then at the same time, and for a month, probably not. But as we continue forward, that's going to happen. And so you got to balance these priorities. And the CDC and OSHA are looking at the nation. We're a smaller entity. They move slowly. We could move a little bit faster. You've got to look at not only your practice individually, but your patients individually. This is what that allows you to do, and figure out what's best and safest for that patient in your office and within these guidelines.
Thank you. And thank you for responding to some of the chat questions. I'm going to just take a couple of them, and I don't know who would like to speak on it. I'm just going to let you all, if you would like, jump in. There's a couple of questions around N95 masks, and then also questions around gowns. Can someone address those quickly or in some concise manner? I don't know if that's either of the doctors or Jeff Allen or even Dr. McKee. If you could, you're more than welcome to chime in as well.
Julie will start, and then I'll place a comma at the end of my comments, and somebody can carry on. Going back to the broadness of it, we're not saying that they have to be disposed of every time between patients. We're saying individual decisions. We're not saying the gowns have to be disposable, to be honest about it. But if your gowns aren't disposable and reusable, you need to think seriously about either getting a certified laundry to do them that does healthcare laundry, or have facilities on site, because hot water and soap does the trick on it. But as we move toward more plentiful supplies, our standards in our own offices are going to change. But until then, we have to use our brains and decide what's going on. If I have just seen a patient that has had 6 extractions and 2 of them were surgical, I probably just don't need to present that look to the next patient and should don another gown. But if I'm doing denture try-ins or something like that, probably not. But it's individual, it's infection control. It doesn't have to be disposable. There's my comma.
Thank you. Does anyone else want to chime in?
Mehek, I'd like to say something if I can.
Yeah.
There's a lot of hygienists out there that are also trying to help along the situation by helping write protocols. Patient safety has got to be our #1 priority. I think we all know what we need to do to protect ourselves. It's just a matter of UPS showing up with everything that we need at this point. But patient safety is our #1, and I think hygienists are in a great position to be able to help protocol and set the guidelines for individual offices. I know I was blessed that my doctor wanted to meet with me at the office and figure things out. We went down the hallway, we looked at each room, pros and cons. We tried to find solutions on how to work things out. The majority of it has not been expensive fixes. The majority of it has been minimal dollar amounts, other than getting washer and dryer for on-site laundry. That's probably been our big one. But I encourage hygienists out there to work with your doctors to come up with office protocol. And doctors, I encourage you to listen to your hygienist about setting up office protocols. Thank you.
Thanks.
I would also just ask that OSHA has lifted some of its requirements regarding N95 mask enforcement. You can find that on their website.
Thanks. And we could share that as a resource, as a follow-up resource to everyone as well. So thanks for that point, Jeff. I know that there's several other questions, and a lot of them are technical questions that we probably can't get to because we can't be here all day. But that's something that we're happy as a team to work through and kind of give you as much information. And I hope that FAQ document that the working group is developing can actually go ahead and help answer some of those questions that you all might have. And we'll make sure that that's sent out to everybody on this call, and then also through each professional organization, so you guys could get that information. So I do want to say that before we move forward with our conversation. And I know a couple of the other chat questions are very specific to what Dean Bradley is going to be speaking on in a couple minutes. So I'm just going to go ahead and turn it over to the Dean, so you could go ahead and share your updates.
Hi, everybody. So what I thought would be kind of good would just be to kind of use my time to show you some of the protocols that we've adopted at University of Louisville while we're in the phase of dealing with emergency care and sort of some of the protocols that we established. And so I'm just going to share my screen here, and hopefully this will work. Let me see if I can do it another way, because I'm not seeing what I need to see. Let me back out of that. Bear with me here a little bit. I'm going to try to get it running, and maybe that might help. So bear with me here.
Zoom is a new thing that we're all learning, so I definitely understand it.
Yeah, let me do this one more time. And I'm hoping I can find this. And we'll share that.
There you go.
Now, I don't think you are hearing it though, are you?
No, we are not.
Okay, let me do, this may be a factor with Zoom that it doesn't show it, but let me kind of be the voice here. So they come in, first of all, they're pre-screened at the door. And as you can see, we have sort of the 6 feet separation. And then from there, they're going to pass in. I'll just let this there. An infection control manager. And so she's going over the forms with the staff, a huddle before to make sure that everybody knows what needs to be filled in, and to record pain level. There's also then showing where the health history form that's specific to the clinic, and going over that again. And then if there's an extraction required, there's the consent forms. And then, again, the process of which staff deal with the seating of the patient, making sure everything is present, and it's all followed through. And it's a morning huddle that quickly goes through. And up here we've got sort of if there's a question that somebody may have answered that raises a flag, that's then brought to a separate chair where a faculty member will be able to do it. There is the fitting of the N95 mask. So there are 4 steps in that. And then we have a chart indicating the required PPE for the different levels of protection that would be needed depending on what that person is doing. There's a little review again, and these are just the statistics that we had in our office for up until April 16th about the numbers of emergencies. And again, this was just to trace our patients and make sure we knew what was coming in and out. So again, part of what the CDC guidelines were expecting and mandating. Here she's showing you sort of, again, what the assistant should be doing. So again, reviewing with them in the morning. Every morning there's a kind of an assistant huddle, and then there's an assistant and a doctor huddle. And so this is the next huddle. And again, this could be very shortened in your own office. This is not meant to be the be all and end all. Just wanted to make you aware of the process. So right now there's sort of a discussion going on with the team about, different aspects of questions that may arise. And so again, it's just unfortunate that I can't play the audio on this. So this is the main huddle with the doctors, and they're talking about, if somebody needs an x-ray, who's going to handle that. Again, just making sure everybody is on the same page, and any questions that anybody has. So our radiology area is just not far off of here, and you'll see the individual PPE that's applied for the different levels of people here. So this is just before everybody's getting ready to go. We kind of have labels on people who are sort of in essence clean. People who are runners that are running a patient between maybe the operatory, the exam operatory to the radiology area. That these are people that don't need to have the same level of PPE, but then they don't get involved in any areas where there may be any contamination. And so that's kind of how this is a person who's going to bring a patient over to our ACB clinic, which is actually outside our main office. So if they require a surgical extraction or something like that, where we have our oral surgery residents, then that's where that person's identified. So they're just kind of finishing it up here. And she's just talking about entering the codes in and make sure all the paperwork is entered and the charts are ready to sign off. And so she's just reviewing the protocol there. Okay, so once the dental assistant is confirmed, the patient is assigned to the operatory. The assistant goes over the medical history form of the patient with particular attention to response of potential high-risk questions in relation to COVID-19. So the assistant is there, so you can see the operatory is there. So you can see we strip away, there's no treatment going on in this one, so this would be even more stripped away. So again, in any aerosolizing area, we are actually clearing away most of our bays and things of all materials that, again, cannot be easily cleaned. And I think that's a good recommendation in your offices is when you kind of go in is to make sure you strip everything away, photographs that might be up on the wall or even artwork. So if imaging is needed, the patient is escorted and seated in the radiology waiting area by a designated runner. And then after imaging, the patient is escorted back to the radiology waiting room by the radio tech and escorted back to chair. So again, this is the patient walking off. And again, try to maintain good separation of folks. And as you come out here, you'll see again, chairs are separated out so that there's good spacing levels in the office. And he's again going to sit here. She'll go into the radiology area, you'll see here. And again, because the patient has been put in, we take cone beam CTs because it's a little easier than even putting a periapical radiograph in there. But we have actually adopted our policy too that our rad techs do wear a facial mask because a lot of times just placing the patient in there can involve the aerosol droplets from the patient to be potentially an issue. So this is the person just walking them back again. Again, patients all have masks on, and then they're seated. There's about 2 minutes left. So this is what a person now who's got an N95 mask on, and underneath this is a level 3 mask. She's explaining she has her gown on, her hat, and she's not wearing her face shield, but typically we'll see her in a second where there'll be 2 different types. So no aerosols are generated in this clinic. However, extractions are performed. If aerosols are to be created, then the patient is referred to our ACB. So again, this was our protocol up until there, and that gives you a kind of a sense of what we're wearing. It's a face mask. You can see that she has not got an N95 under here because she was not involved in an aerosolizing procedure. She does have her mask on, and then a disposable gown. And she could tell you this a lot better than I can. And now you can see she does have the N95 mask on. And again, she will remove this one in between patients and replace it with a new level 3 mask. So the N95 will remain on. Now again, for just the screening of patients, we have an employee entrance and a patient entrance. We separate out. Everybody coming in is screened. And we have a very visible sign here that says if anybody has a temperature, they will not be admitted to the building. So all employees have to enter the building for a mandatory COVID-19 pre-screening. And you'll kind of see then what happens here. They'll come in. And again, we try to maintain social distancing as much as possible. And there's a little bit of a description of what's going to happen. And we're doing this with our patients, at the front door. So all of this is there. They come in, we use our digital scanners here and get a temperature. And if there's an error reading, and this, if people come in the morning and it's real cold, the digital do not work well. So we then give them a Tempedot, which is something that they will place under their tongue. And he will then proceed over and will again sit in areas which have been spaced apart. So he's just kind of checking the time that the minute goes by. And then he leaves. So again, in your offices, that's all easy when you have a bigger building, but you can imagine we're going to have a lot more people in there. So on scale wise, and every person gets that form that they put on them. So we know everybody in the building has been screened, both patient and staff. And so that is it. I'm sorry that I wasn't able to deliver the sound on it. It would have been probably a better visual for you all. But I hope you enjoyed that part. I'll try to stop sharing that so you can get back to it.
Thank you, Dean. That was really helpful to visually see your protocol and your step-by-step guidance. So with that being said, I'm going to turn it over to the other Dean that we have from University of Kentucky. So I believe you are unmuted, Dr. Atkinson.
Hear me?
Yep, you are good.
Great, thank you. Jerry, thank you so much. You just answered a whole lot of questions and stuff about how it is, and that's a wonderful video also. I don't have a video for you, but I will say that this virus has, as you all know, challenged all the way we think and function everywhere, every practice, everywhere around the state. It's been changed. And Jerry and I have some uniqueness about our challenges compared to what you might be facing with your practices, because we have 200 to 400 staff, faculty, students, and stuff around, and that makes it a lot more difficult to control some of the variables. What Jerry just walked you through is very similar to the things that we're doing here at the University of Kentucky also. It's interesting because as dean, as interim dean, I have 2 bosses that I have to deal with. One is our University of Kentucky Healthcare Enterprise boss, which is the clinical aspects of what we do, and the other is the provost, who's my boss from an academic standpoint. So we've got a college of dentistry academically, and we've got a internet. So as soon as the guidelines were placed together, and my compliments to the committee and all the hard work also, we took those from the College of Dentistry and made our plan that would fit all those criteria and took it to the healthcare system and had it approved, which allowed us to carry out and really open up our clinics if they followed all the protocol. But then I had to also take that to our academic provost and say, because we're going to bring students back on campus. Well, our president has made a statement saying that we will have no students on campus until sometime soon. And I just saw it as I was sitting here, an email that said it looks like we're going to start having people back on the campus in August. So the provost and the president said no students, but we need our dental students back because we can't do that remotely. And a lot of the university is out remote teaching. So if you're in arts and science and chemistry, whatever, you've got a lot more remote teaching you can do. And our president said, you want to do all remote teaching. Well, it's, as you all can appreciate, it's hard to remotely teach dentists how to be dentists if they're not in with patients in the clinical setting and being supervised. So we've had to make a special request to our academic situation that we need our students back. And just the meeting I had before this one started was the meeting that we just got our permission that we now can have students back on campus if we follow all the safety protocol that we've developed here. So we have all that protocol, not all in order yet. We are starting to get our students back. And of course, our most significant group that we're getting back is our seniors, because they're sitting, and you can imagine if you're back in dental school, you're ready to graduate, and all of a sudden they say, no, we're not going to graduate right now. You can't see patients. And you have obligations to a practice, obligations to postgraduate training, obligations to a financial debt, which is enormous. How much stress that would put on the seniors. And about 30 of our seniors hadn't finished all requirements. So now we're going to have the opportunity to get them back in about a week or two. They're not back in the clinic yet. We're starting slowly. They're making sure our protocol are all going to be in order. We'll get them back in about another week or two to finish up. We've had a special permission from our provost to have a graduation date of like the end of June, which is kind of unusual. So the graduation date will be listed June 28th or something like that. That's all been work. Our university has bent over backwards to make some changes because of what the virus has done. I'm sure that Jerry has found the same thing at Louisville. So we're going to have that. We have a couple of clinics starting back a little sooner than others, like our oral surgery clinic is back seeing patients on a relatively normal base now because we have all the PPEs in place now, all our protocol in place now. Our president has been, or our provost has been very impressed with the special plan we've put together just for dentists, to the point that when I was at this meeting, our provost said, well, you're going to have to do a lot of pens, because in our protocol is if the patient doesn't have its own pen and we give them a pen, it's their pen now. We don't cross that back to us. So we're going to be that strict with all the protocol. We did have to furlough a little over 100 of our clinical staff. We did that actually last Thursday, which was the same day that in the evening after we we did administrative leave without pay to 107, I think it is, of our clinical staff, because they were here on revenue. It was being generated by the clinical income. We did that for 5 weeks, and we started to see how our reserves were dropping down. So we had to do that. We did that all day Thursday, and then Thursday night, we were as surprised as everyone was when we're in phase 1 and we're ready to go on Monday. Well, so now we already began the slow process of bringing some of our clinical staff that are on administrative leave back into the situation. So we've done that a little bit today with with oral surgery, general practice residencies, bringing some back. But we're going to do this very slowly, and so that we can make sure all our protocol are followed well. Our seniors will probably join us in about another week and a half. I think we're going to, because we just today got the permission to bring them back on campus. We still have yet to work to figure out how we're going to do all of this with our first, second, third year classes, because we have restrictions in simulation laboratories with distances. We have to figure that one out, get some barriers up. And so we're working diligently, but some of these problems are problems that you can only solve slowly and to make sure we follow the protocol. So we've had to make some major changes, as we all have. And some of the ones in schools, when you have as many as really 300, 400 staff, faculty, and such, it's hard to control everything. We got to make sure that we're doing the right thing each way. And as I've heard several times, our main concern is safety, not only for our patients, but our faculty, staff, and students. And we're going to be highly overseeing that to make sure that's there. With all the PE protocol that you read about. So I haven't got anything more to say unless there's questions about how the colleges are getting back on their feet.
Thank you, Dr. Okedson. I really appreciate you sharing your input as well from UK's perspective. There are a couple questions, which should not be a surprise. We have had a ton of dialogue within the chat feature, so I'm really glad that folks are answering each other's questions and providing guidance. So one of the questions was around, is there a video of enhancing disinfection of an operatory? I don't know if it's really open to any of you guys who have spoke today.
I'm not aware of a specific one I could point to. You know, we've actually talked about that internally, about creating some protocols like that and documenting them and sending them out as CE, as free CE. But again, as Jeff has said, we have so many people that have had to be furloughed, and some of them would have been involved in making some of those things. So all of our staff currently are critical care staff, are directed to obviously resuming business, but I think it would be a great resource. And I think there's, maybe Julie, is that something that is out there? I don't know if there is.
Not that I'm aware of. I'm sorry, I got distracted. I just found out a friend of mine had a cancer-free scan today, and she let me know that. So I'll get back with it. But no, I'm not aware of one. I can see that happening. One of the things that I'm seeing on here is this isn't going to work with this, and this is not going to fit. And boy, those are valid concerns. The strange and beautiful thing about dentists is they are a group of inventors. They invent. So I look forward to seeing what's invented for the use for all of us as we move through this. So if you've got a great idea, get it out there to do that. You know, how we fit all the PPE together. But I think invention is going to occur because we certainly have the necessity.
Thank you.
Can I say something, not that, but I also wanted to thank the Kentucky Board of Dentistry, Jeff Allen and Jeff Ball, because when Jerry and I came to the Kentucky Board with an idea that we were going to have problems with our seniors getting licenses in the traditional way, they stepped up to the plate and made some very nice changes that are going to make life easier for these students finishing up. So I thank you for all the cooperation that we've experienced that way. It's been a really wonderful way to get everybody together thinking the same way. So thank you for that.
Here, here.
Thank you, guys. So I am actually going to wrap us up early, knowing that I feel like we've kind of answered several questions. This is going to be a fluid dialogue that we're going to constantly have as we go through these phases of gradual reopening. So I'm just going to take a second to say thank you to all of our presenters. We know this is difficult to share information, especially because everything is evolving every minute, hour, day, week. And so thank you all. And I think the main takeaway here today, just as I'm listening to each of you speak, is we have to work smart with what we have. And we want to keep everyone safe. And so it's going to take us time to be creative, but we need to use our resources that we have currently. And so thank you to each of you all. I know there was a great deal of interest for clarity among the oral health community and also the COVID, especially around the COVID-19. So as a heads up, we as a work group are continuously meeting, trying to inform each other and provide resources and guidance. So we'll be sharing information through our channels for everyone. And I just want to make that note because I know you all have such great questions that you wanted answers and clarity around. Also, I do want to mention this webinar is recorded, and I think I said that in the beginning. So if you want to share this with your networks or with anybody on your dental team or other offices across the state, please feel free to do so. We're going to share a link of this webinar on our Kentucky Oral Health Coalition social media channels, and we encourage you all to post and share and like and follow whatever you need to do on social media to get the message out, because we want to make sure everyone's singing from the same songbook and feels safe and appropriate during this time. Also, I just want to thank everybody that has attended. I know this was, I think we had like 400 attendees that registered, so there's a great deal of interest. So I want to just say thank you for your thoughtful questions and engaging with us this afternoon. And again, this webinar is brought to you by Kentucky Oral Health Coalition. And so we wouldn't be able to provide this information or have this platform to give this information if it wasn't for our members that are a part of the coalition and their membership dues. So if you are interested in receiving similar content or engaging with any of the speakers here today, all of these folks are engaged in the coalition and have their own professional organizations. I would ask you to check out their website and our website as well. So with that being said, I'm just going to say happy Friday, and I hope you have a great and safe day. Thank you all, and I appreciate it.
Mm-hmm.
Bye-bye.
Yeah.
Bye.